السلام عليكم، مرحبا. الفيديو التالي مقدم لكم من ريتشارد تالي، مدير شركة Compliant Medical Devices. نأمل أن تجده مفيد. لا تتردد في الاتصال بنا على البريد الإلكتروني الموضح أدناه إذا كنت بحاجة لأي معلومات إضافية.
The topic for today is to explore a procedural approach in defining the severity scale for risk management. Defining severity, creating an effective scale which is compliant to EN-ISO 14971, the risk standard. We need to define a scale which is appropriate to the device, and the scale needs to be understood by the whole risk team. The risk team is multidisciplinary, and for most medical devices, the risk team is likely to comprise at least one person from design, production, quality, regulatory, and clinical, and it's quite possible that we will have other functions serving as well, such as installation, servicing, post-market surveillance. For the duration of the risk analysis, we want them all to be speaking the same risk language. Every territory has laws in place, and these require risk analysis to be conducted for medical devices. The harmonised standard is ISO 14971, as you can see here on the slide, and it comes with a technical report, TR 24971, which acts as a supplement and guide to the implementation of 14971. The standard requires that a plan is created for each particular medical device. Severity planning is part of this. It's simple enough to think of the severity of harm as a sliding scale, where at one end we have negligible and at the other end we have death. Incidentally, zero harm is not a valid descriptor because it cannot be addressing a hazard, and to be a hazard it has to be able to actually cause harm. It's not unusual in larger manufacturers with many devices to actually see scales like this. Some of them have as many as 10 steps. It's a scale which attempts to provide for every grade of harm. If there are many medical devices being manufactured, then this approach allows for all the devices manufactured to be covered. Since this obviously works, why don't we use this as a method? Well, one reason is that the number, the descriptor, and the description here provide ambiguity when it comes to severity. The difference between any two levels is going to be subject to persistent argument. In fact, looking at this, you could replace the whole table with a sequence of emojis like this. The only measurable anchors in either of these two scales is death at one end and almost no harm at the other. Everything else is up for debate, plus or minus at least one level. Let's look at the severities of harm capable of being caused by a syringe. If the device is found to be cracked or broken, there will be a delay to treatment. This is negligible harm, as the medical professional will simply take another syringe from the box. The syringe seal could fail during use. An underdose would be delivered and there'd be a mess to clean up. The medical professional would have to start again and estimate the balance of the required dose. This would still be a very minor harm. Stepping on a discarded syringe, which could lead to a cut or a fall, which we could call serious harm, is unlikely but possible. Now we have three levels, but serious could be renamed, everything from serious to death. The risk team now have specific examples to work to. The severity scores are appropriate and specific to the device. A syringe pump has very different harms. If the healthcare professional uses a syringe of the wrong diameter with a critical drug, then the worst case scenario could be the result. Pressing keys rapidly and failing to register a key press could lead to an underdose, with the patient not being effectively treated. The needle could miss a vein, which then results in tissuing of the drug when the device is switched on. The patient could be bruised from the needle. line and power cables could inherit the area around the patient. And for negligible harm, we could have a delay as the healthcare professional programs the device itself. The syringe pump obviously warrants more levels of severity, and I guess this is not surprising as it's a more sophisticated device. The key here is to use device-specific examples. So, what have we done? We've defined a scale appropriate to the device. We make a scale which is understood by the whole risk team because it's device-specific. The procedure describes how to assemble the severity table, and the severity table is in the device-specific plan. And what conclusions can we draw? We reduce the potential for bias. We reduce the time because arguments and errors are minimized. And we are expecting that we can conclude that the risk team will work more effectively. Thank you.